Good morning. I would like to thank the organizers for inviting me to this prestigious meeting to talk about EUS-guided gastrojejunostomy using a lumen opposing metal stent. Today, we will have a case of a 53-year-old man with a prior Roux-en-Y hepatico-jejunostomy who was previously diagnosed with adenocarcinoma of the head of pancreas with liver metastasis and afferent loop syndrome. He previously underwent an EUS-GJ anastomosis with a Spexus lens to decompress the afferent loop. He now presents with a gastric outlet obstruction from tumor blocking his efferent limb, and the plan is to insert another lens to create a new GJ anastomosis. The equipment we will be using will be that of a linear echo endoscope. Also, we would sometimes keep a therapeutic gastroscope just in case we need to place a duodenal stent if the lens is unsuccessful. We will use a 0.025 guide wire to cross the stricture. This will allow placement of a balloon catheter for constant irrigation to distend the small bowel loop for puncture, as well as to provide a good locator for the puncture with inflated balloon. We will use methylene blue mixed with irrigation water, and this will be infused via a water pump to distend the small bowel. We will use a 19-gauge standard FA needle to confirm the location of the distended limb prior to the placement of the lens. And the lens that we choose will be a 15 by 10 millimeter hot axios lumen opposing metal stent. We will then dilate it open after deployment with the 15 mm CRE dilating balloon. This is a schematic showing the tumor, which is in red and causing a gastric outlet obstruction. We will want to place an irrigation balloon catheter over a wire to distend the target limb. And this is where we will place the lumen opposing metal stent to connect the stomach to the distal jejunal limb. Over here, you can see that our balloon catheter is being advanced over a guide wire that was previously placed across the stricture. It's important to advance the catheter all the way towards the target area. Here we can see there's contrast injected to confirm the good location. And we will try to inflate the balloon. This will allow us a good target on EUS to see the location for the puncture site. This is the EUS view. As you can see, the balloon is on the left and we have the needle puncture. We will sometimes aspirate to look for blue methylene blue to confirm location. And here we have the deployment of the lens with the distal flange deployed, followed by a constant traction to provide tenting and opposition. And over here, we will see the luminal site deployment of the proximal portion of the flange through the working channel. As you can see, as we slowly remove our delivery system, you can actually see that there'll be a gush of blue to confirm that we were in the right location and not in the colon. Here we are dilating the axios lumen opposing stent to 15 millimeters. And over here is a fluoroscopic image showing a dilation of the axial stent with a good contrast flow down in towards the jejunum. We sometimes confirm the placement of the lens by advancing a gastroscope towards the lens. And over here, we can see as we enter the lens, we can see that there is good flow of contrast, sometimes on the fluoroscopy, going down to the jejunal limbs. And must be careful though that you do not dislodge. This is a patient 5 months after we have placed the lamps. As you can see, the previous lamps in the afferent loop, as well as the new lamps connecting the stomach to the distal jejunum. He was tolerating orally well, and he died from disease progression or metastasis rather than gastric outlet obstruction. So in summary, we must be able to distend the target duodenal or jejunal limb for puncture, and this can be accomplished using a balloon catheter, nasal jejunal tube, a dedicated balloon device such as the E-Pass, or direct irrigation with an endoscope. The puncture can be initially done with an FNA needle as a guide to confirm that you're in the right limb, and this can be done with contrast injection or aspiration of blue dye from the distended limb. Subsequently, a direct puncture of the hot axios lumen opposing stent after FNA needle is removed is now recommended. The reason being is that over the wire placement of hot axios can sometimes risk pushing the small bowel away as we advance the wire in. Correct deployment of lamps is critical to avoid mal-deployment, and this can result in a perforated bowel. Thank you for your kind attention.